Yeah. Good afternoon, everyone. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Hope you all have a good afternoon this today because we have a great presentation with us regarding Ebola. In this webinar about Ebola, what we have to know on preventive and respond to this outbreak nowadays. So this webinar, we will have one speaker, which is Professor Martin from Amsterdam, and then through these 2 hours of webinar, we'll talk about Ebola and what we need to know and we are uh, what we can prepare in advance and respond regarding this outbreak, even though the outbreak is still in Africa. And then we are also provide, because this webinar will be in English by Professor Martin, ya dari kami juga menyediakan interpreter atau penerjemahan di Zoom, ya terus Zoom dari menu More, itu nanti Bapak Ibu bisa mengklik di bagian situ ada interpretation. So each of the participant could click the more buttons in the Zoom and then choose the interpretation. And then if you want to listen in Bahasa Indonesia, you can choose German, and then it will show as you will hear the interpretation as Bahasa Indonesia. And then if you want to listen to the English as language, you can choose English. Or you can choose the original audio if you want to turn off the interpretation. Okay. And then regarding the registration, there will be a link for registration, but after the session is ended. So don't go anywhere after the webinar is ended, because after that there will be a registration link. Ya, jadi Bapak Ibu setelah selesai webinarnya di akhir nanti akan ada link terkait absensi. Nanti mohon ditunggu. Jadi absensinya tidak akan diberikan di awal, tapi akan disampaikan di akhir. Kemudian untuk Bapak Ibu yang akan bertanya bisa menggunakan fitur Q&A. So for participant that want to raise a question or ask Prof. Martin, you can put your questions in the Q&A feature in the Zoom. If there is no Q&A feature in the Zoom, you can choose, you can try to look it in the more button. There you can put your question in the Q&A feature in the Zoom. And then later on, we will collect the question and ask Prof. Martin to answer. I think that's all regarding the administrative things for this webinar. Okay, so without further ado, maybe we will have Prof. Martin. Good afternoon, Prof. Martin. Can you hear me?
Good afternoon, Ayu.
Okay.
Thank you.
Yes, thank you for joining us in this webinar because, as you can see, there is a lot of people that wondering about Ebola, and because as we know, the news is saying that the case it keep increasing in Africa, even though in Indonesia we still haven't got any suspected case yet. But still, it's quite interesting to see what we need to know and how to prevent this. So maybe we can have before start regarding the CV. So this is the curriculum vitae from Prof. Martin. He is a professor of tropical medicine and travel medicine in Amsterdam UMC, also clinical work group leader, and then director in Masanya Medical Research Unit in Sierra Leone, and also adjunct member and professor in Institute of Infectious Disease and Molecular Medicine. As we know that also Prof. Martin already also have experience and technical expertise regarding Ebola. And Prof. Martin also internationally recognized expert in tropical medicine by publishing quite many peer-reviewed papers, around 730 with Scopus Index 88. So then, without further ado, Prof. Martin, you will have around 50 to 60 minutes of presentation, and then after that, we will have a question and answer session. Are you ready, Prof. Martin?
Yes, I am. Good
Okay.
afternoon, everybody. Many thanks for your very kind words. It's a pleasure and honor for me to be there with you this afternoon. Can you hear me all right? And can you see my screen?
Yes, we can hear you and see your screen.
Very good. Thank you. So then I would say I start without much further ado. Why are we meeting today? There is another Ebola outbreak, which is developing into one of the major outbreaks to date. And that was the reason to visit and revisit this disease. The talk will be in two parts, more or less. We will establish the basics first, because I do believe that Ebola and other filovirus disease is rather exotic from your perspective. So we will discuss the biology first, the epidemiology, clinical aspects, and other topics of relevance before we focus in the course of the meeting onto the current outbreak. I have no conflicts to declare in relation to this talk, and we'll start with the basics. So very often Ebola, it doesn't really matter. It depends on where you are coming from, how you pronounce it, is dubbed a viral hemorrhagic fever. And you will see that this is a sort of a misnomer for a couple of very important reasons. So one is, firstly, more or less the same clinical picture can also be caused by other infectious agents. So you will learn that there are many bacterial and other infections which can mimic the disease or can lead to a very similar picture. So we are slowly but steady abandoning this term. Furthermore, you will see, and that's much more important, that only about 20% of all Ebola or filoviral disease patients will develop the hemorrhages, which are considered typical for the disease. But more dramatic, because that has implications for recognition of the disease and its management, you will also learn that Ebola belongs to one of the few infectious diseases where not necessarily everybody exhibits a fever, and that can have dramatic consequences. Now, the overarching term is still very often viral hemorrhagic fever, but as I said, it's different diseases caused by different viruses and other agents, and the shared feature is the possibility of serious bleedings. Now, where does Ebola virus belong to? Ebola virus belongs to the family of Filoviridae, however you want to call them. The word comes from the Latin phylum, for a thread. And if you look at the virus under an electron microscope, it's very unusual for a virus. It's not round, but it's long, and it's in part coiled. Now, looking at this structure, we understand already why this is not a pathogen which is easily transmitted aerogenically, because you can easily imagine that such a rather lengthy and complicated structure doesn't really fit well into an air droplet. And this is something very important we can already learn from the structure. Further, we can see that, like every virus, we do have the genetic material, an RNA genome in that case, which is simply wrapped by 2 or 3 layers of protein. This is really a transmission machine, if you want to say so, because what's so characteristic for the virus, a feature shared with many other viruses, but still of importance, is that its surface is speckled with glycoprotein spikes, small spikes, which have an enormous propensity to moor onto almost every human cell. This is quite unusual, mind you. For example, my most respiratory viruses, they need the epithelium of our pharynx where they can replicate and then cause havoc. That's why we are having a throat pain when we are developing a common cold, as we call it. But these viruses can really moor onto almost every cell. Excuse me. Now, we will focus on Ebola virus, and within the species of Ebola virus, there are even 6 species. The 6th one is not even here on the list. I will add it. And Ebola virus is part of the Filoviridae family. So we have Ebola virus, and then we have the very, very, very closely related Marburg virus. There is hardly any difference in the genome between Marburg and Ebola virus. The biology is slightly different, but with regard to interspecies genome variation, Marburg lies very close to Ebola. Then we have an outlier. I'm mentioning it for comprehensiveness. And after this talk, you can readily forget about it, at least for the time being, because we have never seen any practical implication until now, at least regarding humans. But the interesting thing is that whilst Ebola and Marburg virus are more or less confined to Africa, there is one exception, and I mention it, but exclusively causing disease in Africa, Cueva-loviovirus is a virus which has been identified in Europe, not in humans, but in Southern European, mainly Spanish bats. But as I said, up to now, there's no spillover into humans. We don't know whether that will remain the case, but until now it's not. So you can forget it for the moment. So if we focus then on Ebola virus, there are 5 species listed here. In principle, it's 6. Zaire Ebola virus, Sudan Ebola virus, Budibugyo Ebola virus are the 3 of clinical relevance. Zaire Ebola virus sticks out here because it has caused the majority of outbreaks up to date, and also the largest outbreak to date, with about 28,000 cases in West Africa about a decade ago. Sudan Ebola virus is good for the 2nd most number of outbreaks over the years since we started recognizing and recording them back in 1976. And the relatively new kid on the block with regard to a causative agent for human disease is Budibugyo Ebola virus. All these 3 viruses, as you will see, overlap in their epidemiology. They are all at home in the region of East Africa, where it expands into the vastness of the Central African rainforest. So Democratic Republic of Congo, former Zaire, Sudan, Uganda, and surrounding countries are in the epicenter of the repeated outbreaks. More or less the same applies to Marburg virus. Now, there are 3 other viruses which I want to mention at least briefly. There is Thai forest virus. Thai forest virus is at home at Ivory Coast. As you can see, we are not continuing with this practice, but these viruses have been named after the places where we witnessed them first. This is also the reason for the outliers here. Marburg virus in the Filoviridae family is an exception because Marburg is a small university town in Germany, and this is, of course, not where the virus originates from. It originates from the same region as Zaire, Sudan, and Budibugyo virus. But the first cases have been recognized in 1967 when German scientists experimented on an onco vaccine in the university town of Marburg and fell ill after having been exposed to scratches and bites from monkeys from Central Africa. Now, Thai forest virus has so far been responsible for causing one single case in humans. But we know that the seroprevalence is higher in this region, so that might at a certain stage become a new kid on the block. For the time being, it's not further relevant. Then I should mention, and it should be added to the list in due course, is Bombali virus. Bombali is a region in Sierra Leone, close to the border with Liberia. And there we know that there is another species at home. It has not been causing human diseases so far. And now comes the outlier. That is very important. And if we were in the same room, I would now ask you, where is Reston Ebola virus at home? Now, this is very mysterious because Reston is a small town in Virginia in the US. And this is where also a spillover into humans was recognized, not causing disease, but seropositivity when scientists there experimented with monkeys. And they thought they were clever because they were experimenting with monkeys, not from Africa, precisely for the reasons mentioned, namely that many of those species harbor Ebola viruses and other viruses. They thought they are clever, and they experimented with monkeys from the Philippines, after all places. So Reston Ebola virus is an Asian Ebola virus, but up to now, we have never seen human cases. We see some seroprevalence in the area of the Philippine archipelago where these macaques are at home, but it hasn't caused any disease. So if you want to be very sophisticated in your scientific exchange with your colleagues, then you can agree, yes, Ebola is a disease which up to now riddles only the African continent. But if you are asked, are there Ebola species outside Africa, then the answer is yes, there is one, which is Reston virus, which occurs in the Philippines, not related to human disease so far. And in the broader family of Filoviridae, there is a really exotic one, which is Equeva loviovirus, the European filovirus. So the first take-home message is, in principle, the family of the Filoviridae is not limited to Africa, and in principle, up to now, disease is limited to Africa. Very important to know, and in the future, in the rest of the talk, we will be focusing on these three species of Zaire, Sudan, and Budibugyo Ebola virus. Here I mentioned already where the outbreaks occur. This is not only, and here we focus on Africa, rightfully, because as I said, there are viruses outside Africa, but they have never been linked to causing disease. And as you can see here, the majority of the outbreaks has been caused by Zaire Ebola virus and Sudan Ebola virus so far, with Zaire really being responsible for most of the outbreaks. So how do we characterize outbreaks, and what would be a classical Ebola outbreak? If you look at this region, then most of the cases known to date occurred in the Central African rainforest region. And that has to do also with the reservoirs which harbor the disease. I'm touching upon that within a couple of minutes. But what is important to know is that the average Ebola outbreak is very small. If we look at the first outbreaks in 1976, almost in parallel in Uganda and in then Zaire, we are talking about a handful of persons. And usually the outbreaks occur in remote villages deep in the rainforest. And what happens is that a group of hunters will venture into the rainforest. And may I ask you, there is somebody who is not on mute. If you would be so kind to mute yourself, I'd greatly appreciate.
Prof. Martin, I think you get mute. Sorry, Prof. Martin, your sound is got muted. Hello, Prof. Martin, could you hear me? Hello, Prof. Martin. I think your voice is got mute.
Okay, I'm very sorry. When did you lose me? Can you hear me?
Hello, we cannot hear you yet.
Still.
Wait.
I'm not on mute.
Hello, Prof. Martin. Can you hear
Yes.
me? Okay. Now, yes. Yeah, now, yeah. Okay. Sorry for the
I'm not
technical
on
problem.
mute, actually. I don't know what happened.
Yes, maybe there is a technical problem. Sorry. Sorry
When
for the
did you
inconvenience.
lose me? When did you lose me? So I'll go back to where you lost me. What was the last what you heard from me?
I think you're talking about the current Ebola, about the
The
distribution of
current
case,
outbreak. Okay.
distribution outbreak of Ebola is quite limited.
Yeah, okay. So what I was saying, did you hear my description of how outbreaks usually occur? Namely, that they afflict small groups of hunters deep
Yes,
in the West Africa. You heard that, okay.
yes.
And then
Up
I
to that.
was starting, I don't know what happened. I'm not on mute. So anyway, let me go back. I was alluding to the fact that there was one very big exception so far, and that is the outbreak in West Africa, which from December 2013 up to 2016 caused about 28,000 cases. And that, interestingly, Budibugyo, which has been responsible up to date, including the current outbreak, only for 3 outbreaks, has already contributed the 2 second and third biggest, with the current outbreak being the 3rd biggest ever recorded in history, and it's growing. Actually, here again, the map of the Ebola outbreaks. Here quickly, the
Oh,
region
Prof. Martin,
where,
sorry. I think your screen got turned off, the share screen in your place.
sorry, you can't see my screen?
Yes, maybe you can reshare your screen because I think it's still not in the Zoom.
Strange. Can you see my screen now?
Yes, we can see your screen.
It's very strange. I don't know why. I didn't mute myself and I didn't stop sharing the screen, but this is what you get sometimes. So can you hear me all right? And can you see my
Yes,
screen?
we can hear you and see your screen. Thank you,
Okay,
Prof.
very
Martin.
good. Okay, now we are moving on to the region where the Ebola virus is named after. This is a small river in the border region between Uganda and Zaire. Here, that was the first case. And this is the map of the area in West Africa, bordering Guinea, Sierra Leone, Liberia, where the biggest outbreak ever took place. It started, we know that by now, with a 12-year-old boy who apparently got in touch with bat feces and somehow got infected. This infection or this outbreak started in a region completely different from the remote rainforest areas where the virus is at home. Here you have a very busy, well-connected region between 3 countries, lot of cross-border traffic, and this outbreak spread like wildfire to grow out into a episode of more than 28,600 people confirmed or probable or suspected, highly suspected cases with more than 11,000 deaths. Now, the interesting thing and the very important thing we should know is that a little bit like COVID, of course, the comparison is limited, but the real problem with Ebola is if you look at the number of cases, there are more people per day who succumb to malaria, maybe dengue, tuberculosis, and other infectious diseases. But the problem is that Ebola kills collaterally because the whole health system is going to collapse. People are fearing to get infected in hospitals. Healthcare workers are hesitant to continue working because they fear that they get infected. So a whole country grinds to a halt economically, healthcare-wise, once it is affected. And that's the real problem with Ebola. Here again, the number of cases in this outbreak. Sierra Leone bore the brunt of the disease, but Liberia, Guinea were also infected. Yeah. A word onto the pathogenesis. Sorry. What is important to know, and I mentioned it already, is this enormous propensity of the virus to afflict almost every, or to enter almost every human cell. This is extremely unusual. The virus, once it penetrates, only intact skin cells cannot be penetrated. But the problem with our skin is that we always have microscopic lesions, which are so small that they don't even cause pain. And once the virus gets in touch, the virus will be entering through skin cells into deeper layers, into the bloodstream, and then it has the propensity to infect almost every human cell, and that has consequences clinically, of course. I will be alluding to the reservoirs in due course, but first the clinical presentation. If you look at the clinical course of what happens about 14 to a maximum of 21 days after you have been exposed to Ebola. The problem is that the disease signs and symptoms are very unspecific. So if we look at the beginning of the disease, there are at least 30, 40, 50 other infectious diseases from harmless to very serious, which we could discuss here. And only when the disease progresses does the disease become more specific, with some patients deteriorating, developing maybe hemorrhages. But the important thing is that the main symptoms with Ebola are probably watery diarrhea, and most of the clinical problems are related to the rapid fluid loss. Very important. As I said, the diseases look all the same. This is, of course, a thick film of a malaria patient. We see lots of trophozoites, malaria parasites, falciparum parasites. Malaria is good for about 50% of all diagnoses in Ebola suspect patients. Of course, you can have both, but usually it will be the one or the other. So even in an Ebola outbreak, it's still about 50% of all patients who rather have malaria. These extreme forms, as I said, are not even specific to Ebola. what we see in the upper pictures could as well be caused by snake bite, for example. There are also lots of conditions, including arboviral diseases, which make your conjunctiva bleed, and you will not really observe this in a large number of patients, even when they are ill. We have been discussing clinical presentation, so important to know. Ebola is feared for its propensity to cause severe disease. There are death rates, mortality rates mentioned up to 100%. Well, that is true, but we need to keep in mind that an outbreak is defined as one case above the average number of cases. And because Ebola is otherwise absent, one single person can account for an outbreak. And if this person dies, we have to do with 100% mortality. If this single person survives, we are talking about zero mortality. So we need to look at bigger outbreaks. And what we usually see across all the species is a mortality rate sometimes about 30 to 40% at the end. So if you calculate 11,000 deaths among 28,000 cases in the West African outbreak, with Zaire virus being considered the most aggressive, then you are there. And at the beginning of every outbreak, there are calculations that Budibugyo or Sudan might be slightly less or slightly more dangerous in terms of propensity to kill, but we can assume that in most Ebola outbreaks, particularly the larger ones, the mortality rate will amount to something of a maximum of 30 to 40%. That's of course 40% too much, but it's not that Ebola kills everybody who falls ill. Moreover, there are also mild cases which might be difficult to discover. There might also be, and that makes it much more complicated, people who do have no fever. Only very few have bleeding complications. Diarrhea, vomiting is most important. But if you look at this publication of the first 100,000 cases during the West African outbreak, you see something very interesting, and that is that the scale stops at 85% of all patients when it comes to fever. And that's very dangerous, because also for onwards nosocomial transmission, because we consider fever obviously as the most important symptom. This is reflected, though these were 1,000 cases reported 10 years back, but this was reflected in the small hospital in which I worked in West Africa, in Yele, which is in Tonkolili district in central Sierra Leone. There, in the course of the outbreak, we saw 22 Ebola patients, and in green, I have highlighted the fever occurrence. And as you can see, there are 5 out of 22 patients who throughout their illness, from beginning to recovery or death, had no fever. And the red circle indicates the 1 out of 22 patients who over the whole episode of disease, and you can see the crosses indicate those patients who succumbed to their infection, there was only 1 with bleedings. That highlights nicely why we think we should abandon the term hemorrhagic disease. This might be too small to read, but what this is about is this point which I personally consider extremely important. These are some studies from Africa, mainly from Sierra Leone, but also from Liberia and Guinea, where people looked into the percentage of confirmed Ebola patients with fever. And the shocking thing here is that in some settings, only 60% of patients had a fever. In another one, it was 96%. But still very important, even in a patient without fever, you might not dismiss the diagnosis of Ebola easily. This is the other point, illustrating the other point I made earlier. Ebola kills basically through the destruction of the health system. Here you can see on the left side a very simple hospital statistics of a secondary hospital in that case Sierra Leone, again the Yele hospital, and you can see fair numbers of outpatients and inpatient, of deliveries and surgery. This is how a hospital works in the tropics. And here you can see the Ebola effect. All of a sudden, there are some Ebola cases. There is an outbreak declared, and people stop going to the hospital. Only when you, and I don't have much time to elaborate on this, if you then create a safe environment where, and I'm not talking about treatment centers which only filter out Ebola patients and treat them, they are essential to turn the tide within an outbreak and stop the outbreak. But what we really need is what we don't have, and that is what we did in the West African outbreak. Safely reopening a normal hospital, which doesn't focus on Ebola care, but in unsafe times provides circumstances where outpatient clinics, inpatient clinics can be run safely, where even surgery is done. And the key to that is that you consider everybody until proven otherwise, whether he or she has risk factors or not, an Ebola case until tested twice within the first 12 hours after admission. So that is my credo. I think this is an underviewed or under-recognized part of the whole story. It doesn't stop with taking care of the Ebola patient. The key is to rebuild the health system while the outbreak is ongoing in a safe way. Only then can we provide the necessary level of care to all non-Ebola patients, whether it's people with fractures, whether it's women who need to deliver safely, you name it. Yeah. Now, what about the Ebola reservoir? How is the disease reaching us humans? So with Marburg virus, it's clear. It has been established that the African fruit bat, Rosetus aegypticus, is responsible, is the, let's say the replication vessel, is the definitive host. The bats are not falling ill and they can transmit the virus. Probably mostly they are no carnivores, probably via their infected saliva, which clings to fruit and vegetables, which is then on which they nibbled, which is then eaten by other animals. This is probably how other animals fall ill. And amplifying hosts will say animals which can also become ill from the disease are monkeys and apes, and also antelopes and others. And usually transmission is via the consumption of the meat of ill mammals which have been infected to humans. And when these humans fall severely ill, the virus will be expressed in almost all their bodily fluids, and that leads to nosocomial and other onward transmission. Here, the fruit bats, there are 12 species which look very similar. They are distributed all across the continent and as far as to the fringes of Asia, on the Seychelles, for example, you find them as well. Theoretically, if consumed as bushmeat, you might also get infected by eating bat meat, but that is usually not the case. Usually the primary cases in a human outbreak are via consumption of bushmeat from infected animals. Now, how does onwards transmission work? And that's a real problem, because the Ebola virus is expressed in all bodily fluids. Of course, in feces, in urine, but also in saliva, in lacrimal fluid. And as well, and that we learned the hard way, it can also be harbored in the prostatic gland. And what we learned during the last Ebola outbreak in West Africa is that recovering males might be harboring who are healthy afterwards, after the survived Ebola episode, but they might continue harboring the virus, and they might transmit the virus to their sexual partners. And that's very tragic, and it has been documented now in quite a number of cases, and not only months after their recovery, but also years. And you can imagine that has tragic consequences. Now, probably the most important bodily fluid which leads to onward transmission to household members, to community members during burial ceremonies, where usually a whole village communities still touch the body of the deceased. Now, the virus doesn't only sit in blood, vomit, diarrhea, as I said. Even in an apparently clean body, the virus might survive on its surface in sweat. And this is probably what is responsible for quite a number of these secondary cases. Diagnosis, once established, is very simple. The gold standard is RT-PCR, and usually we would do that in a safety level 4 laboratory, as far as available, at least when it comes to testing imported cases or suspect cases, maybe in the US, in Europe, or somewhere in Asia. In the field, these techniques are not readily available, and at the beginning of an outbreak, one doesn't necessarily think of Ebola. But once treatment centers have been established, I have witnessed that in West Africa, RT-PCR can be done safely if we know what we are dealing with in makeshift laboratories, where in a vacuum tent where you only insert your hands, you can handle the samples safely. So RT-PCR, quantitative PCR, is very, very important. And quantitative, why quantitative? We need to know how many replicative cycles are needed. The fewer are needed to indicate the virus's presence, the higher the infectivity of the individual. The higher we get, if we get to 30, 40 cycles to replicate the virus, then somebody might already be close to being non-infectious, actually. Right. These are the basics of Ebola. And if we were sitting in one room, I would say I'm going to take questions now. But we are going now to visit the current ongoing Ebola outbreak. And whilst we are doing so, I'm explaining why, on the one hand, we have many good news with regard to prevention and treatment, and why this doesn't help with the current outbreak. So this is what we reported in the Emerging Infectious Subcommittee beginning of June. Here, the outbreak was already going for a couple of weeks, probably. Excuse me, probably the index case occurred around 24 April in a very remote area of the DRC bordering Uganda. There have been some cases also imported to Uganda, but they are not autochthonous. It's an outbreak which evolves principally in the border region, Northern Province, Ituri Province, close to the border of Uganda. And already when the public was informed for the first time, WHO learned about the outbreak on 5 May, on 13 May, first news were put out. And in the second half of May, it became clear that this outbreak had already amounted to a number of cases, which places it already third in all outbreaks of Ebola disease ever witnessed. In a rapid assessment, we tried in the second half of May to characterize this outbreak. So you can see here the region of the Democratic Republic of Congo where this case occurred. And DRC is a gigantic country. It's as big as the whole of Western Europe. And if you want to translate it into covering the land mass of Indonesia, you can fit quite a big part of the Indonesian archipelago into the country. I do believe Indonesia stretches for more than 5,000 kilometers from east to west. The Democratic Republic of Congo does so for over 3,500 kilometers from the Atlantic Ocean to the Africa of the Great Lakes, almost reaching the other side of the continent. And here the outbreak unfolds. Imported cases were also in Kampala. Key challenges here are manifold. There is healthcare-associated transmission. There are community deaths. And the main problem is it's an area of insecurity and conflict. Populations are mobile across borders. There is limited laboratory capacity. And one big problem to propagate the outbreaks are unsafe care and burials, which are so deeply rooted into the cultural practice that it is very, very difficult to interrupt transmission very easily. And priority areas in the early outbreak response are, of course, the early detection and isolation, the rounding up of this outbreak, the strengthening of the lab capacity and the treatment capacity, then very important infection prevention and control. In the first place, we want to avoid further spread, but in order to achieve that, you need to engage with the community. You have to change burial practices and many, many more. Looking at the challenges of this particular outbreak in our rapid situation assessment by the Emerging Infection Subcommittee of ESCMID, we alluded to two things. One is the complexity of the region where the outbreak happens, with civil strife, with war riddling the area since many years. But also the other problem is that with Budibugyo Ebola virus, we do not have vaccines, we do not have monoclonal antibodies, which have been developed 10 years ago, but which are more or less specific against Zaire Ebola virus. Again, the situation at a glance, how does this outbreak evolve? End of May, WHO reported a total of 906 suspect cases, 134 confirmed cases with 18 deaths. 1 week later, 2 days ago, we have already 515 confirmed cases with 91 deaths, and the outbreak is still far from being under control, though that will go on at least for months, if not longer. And it might be that this outbreak is still overhauling the other outbreak from that area, which riddled this part of Eastern Africa a couple of years ago. What am I alluding to? So Budibugyo happened twice so far. There were 2 outbreaks of Budibugyo virus in the area, not precisely there. The first outbreak was in Uganda, but on the other side of the border, in 2007, and with 150 people. And 5 years later, there was another outbreak in the same area on the other side of the border in DRC, with an outbreak afflicting about 50 people. And as you can see, the dimension is much bigger. But the problem here is rather that the area is a geographically and politically very, very difficult area. This is the outbreak situation at present. The cases reported in Uganda, in Kampala, they are, as I said, secondary. There is no local outbreak activity there. Okay, Let us look at treatment first. What are our treatment options? And the pictures here are from the area I worked in during the large Ebola outbreak. This was a treatment center somewhere in Sierra Leone. So what treatment options do we have? Now, in theory, if it was a different virus, namely Zaire Ebola virus, we would have maybe some not that well working antivirals. We would have monoclonal antibodies. We might have convalescent plasma. I'm going to allude to that later. But the more important thing is it is all coming down to supportive care. And that makes all the difference. As I said, Ebola patients are very seriously deprived of fluid. They need to be resuscitated with fluid as long as possible with oral fluids. Also, what we do differently from everything we learn and teach in infectious diseases, usually before treating a patient with antibiotics as targeted as possible, or before administering an antimalarial, we would establish a diagnosis. And if we would need to act quick, we would at least obtain materials before we would start these interventions. But the golden rule in Ebola suspect patients is that we administer, even without further diagnostics, broad spectrum antibiotics for two reasons. One is almost all Ebola patients develop a secondary bacterial disease. And the other reason is that in the first place, many bacterial conditions such as meningitis, bacterial sepsis, typhoid fever are high on the list of differential diagnosis. And as I said, malaria is good for 50% of cases in all suspect cases. So it's wise to administer those drugs. And of course, we want to keep blood taking and other things to an absolute minimum with these patients. So that is our strategy. And what we see is, I alluded to death rates already, but usually the death rates at the beginning of an outbreak, when there is a complete lack of care, is very, very high. And at the end of an outbreak, it's almost zero. And that is why we arrive usually at 30 to 40% mortality rates. And the difference is made by these unspecific enhancements of level of care. You can't read this. It's too small and you don't have to. I'm making a point here that the other outbreak, which was hitting that area, happened in 2018. And the difference was it was Zaire Ebola virus. This outbreak took very, very long as well, precisely the same region, to bring it under control for the same reasons. This is an area of civil strife and of disruption. The terrible thing, what happened was that over the course of 2018, 2019, there was a lot of opposition to re-establishing healthcare. Many healthcare workers were killed in that conflict. There is a figure of about 100, from high WHO officials to local nurses. And that explains a tragedy, or highlights a tragedy, because this outbreak in the same region where we are dealing with now, we had all the tools before there was the West African outbreak. So vaccines readily at hand were in place. There were some drugs which would have worked, but due to the disruption of the health services, that didn't help, and this outbreak grew out to the second biggest in history. And now we have the dilemma of a double problem. It's the same region, very difficult to help, and our drugs and the vaccines don't really work. Quick work on what works with Zaire Ebola virus. This was the so-called PALM trial, where during that outbreak, it was shown that remdesivir, the antiviral which was developed against Ebola and which the company owning the rights then repurposed against COVID, against which is also doesn't work very well, at least if given late. This we learned doesn't work. But what we learned is that so-called monoclonal antibodies work. And that work is based on the recognition that at least in some settings, and it cannot always be reproduced, as this paper in the New England Journal showed from the outbreak in 2016, but it has been shown before in desperate situations that if we gave reconvalescent plasma, so blood plasma from patients who just had survived an Ebola outbreak, if he gave that to patients at the end of the outbreak, the odds of survival would be better for those patients. And we learned from this, of course, the agent which makes it work are monoclonal antibodies. Monoclonal antibodies designed to cap the parts or the whole of the glycoprotein spike which the virus uses to moor onto human cells. And this development has been brought forward. That was an early review from my group from 10 years ago, where we learned to combine certain of these antibodies and put them into drugs. And the nice and good thing is it works. The only problem is, and it's a big problem, or there are three problems. One problem is it is species specific. That's easy to imagine. So it doesn't work with Sudan and Budibugyo virus. And the other problems are that it takes a while to design them, and it's very, very tedious and costly and complicated to produce them in vast numbers. So in principle, we do have a tool, at least against Zaire Ebola virus, but in practice, it still remains difficult, but it's there. Now, if you wonder why don't we have them for the other viruses, first of all, they are under development. So there is a 2-antibody pan-Ebola virus cocktail, which seems to work in early animal testings. And usually it's ferrets in which these interventions are tested. But we do have also, and if they work in such a model, then we go to the macaque model, which is so good. The results are so excellently, formidably translatable from monkeys to man that we usually only need a handful of animals to be sacrificed to prove that monoclonal antibodies or vaccines work or don't work. And there is some work in progress here. We are not going into detail, but this is an illustration which should show that these antibodies are in the making. Whether they will be arriving timely to curb this outbreak, this ongoing outbreak, is not entirely clear, probably rather not. So we have to rely up to now on tender, loving care and improving basic clinical services. What about vaccines? There are many, many, many vaccine platforms and which are suitable to be exploited for Ebola vaccines. And the interesting thing is that many of those vaccines, it's easy to develop a vaccine against Ebola, much easier than against many other diseases. But the problem is, if you want to develop something like that, which has been resting on the shelf since long with proven efficacy in animals, the problem is you still need clinical trials to put them to the test. Now, what do you do if you want to invent a vaccine or a drug against the most prevailing diseases in your area? You would develop a vaccine against dengue or a antiviral in your setting. You have lots of cases. At any time, you have well-established research infrastructure. And that is the problem with Ebola interventions. The voices are very loud which say, why hasn't it been developed before? It's because nobody cares. Well, this is too simple, actually. The problem is Ebola only occurs in outbreaks, and they occur under difficult circumstances and in remote areas, and they are usually short-lived. So you really need very big outbreaks which go for very long in order to push vaccines and drugs through the development. And that happened during the West African outbreak. Very quickly, we were part of this team. Phase 1 trials were initiated for Ebola vaccines, which were already resting on the shelf. There was an enormous acceleration of clinical development. This is a first initial report contradicting our usual practice in writing up science, where we would really clean our results, analyze them thoroughly, and then publish at the end. But because the development needed to be very quick, studies were done, reports were made even when the trials were still undergoing analysis. This is to show the difficulty of an Ebola vaccine trial. Imagine you want to do a clinical trial, there is an outbreak, desperate situation, people would be willing to partake in a trial. But if you tell them, sorry, we need to do it blinded and half of you will not receive the vaccine. Now, this is a very difficult message when it comes to Ebola. So novel study designs needed to be invented. And the idea of ring trials was created where in some villages, people who were at risk of developing Ebola would be vaccinated directly. But the other group would be vaccinated as well. The vaccine would not be withheld, but it would be given 14 days later, which obviously doesn't offer full protection, but at least some of the people who would receive or everybody in the trial would receive some protection as compared to somebody who would not receive a vaccine. And with these sophisticated trial designs, it was possible to show that that there are vaccines which work well against Zaire Ebola virus. And here you can see this is the second publication is almost identical in title with the first one from 2 years earlier. And when I read these study results, the fascinating thing is we can really accelerate things. The second trial the report was almost identical to the preliminary results on which we based further action. So at present, we do have 3 Ebola vaccines in 2 groups, actually. The RVZV-ZBOV vaccine called Ervibo is a single-dose vaccine, which induces very quickly, still in the incubation period, a protective immunity, but it's short-lived. So that is, and it cannot be boosted. So this is ideal for the for outbreaks. The other one is a combination of 2 vaccines, one given as primer, one as booster. It takes very long to induce immunity, and you need to wait 8 weeks for boostering. Well-working vaccine, but not suited for outbreaks. And both are limited to Zaire Ebola virus. It doesn't make much sense to put them to the field now. This is to show the enormous acceleration of a clinical trial scheme, which usually would have taken 10 years. It took 1 year for this clinical development. So we were rushing things as quickly as possible. But if I'm saying 1 year and we are looking at the current outbreak, then it's clear why at present we have to relate to improving standard care rather than interventions. And here, this is a work from my group. We have a strong interest in looking at factors associated with acceleration of clinical trials. It's already very quick what we can do in an outbreak, but still we will need a year or so to develop interventions. The other virus is Sudan virus, against which there are also some vaccines in development, but we are not there yet. And these are two developments which will be now put to the test in the current outbreak. There are candidates for a pan-Ebola virus vaccine, which can be administered like a nose spray. And this one is under development. We don't know whether we'll see it reaching the end of its development during this outbreak. I'm not going into detail here, but I can show you here that it's very promising and working. And then there is also one specific vaccine against Budibugyo, which is in progress and which has been proven to be effective in animals and which is now going to be put to the test. Here are some details I'm not alluding to. 2 weeks ago, there was not a single study in the most important trial registries against Budibugyo Ebola virus. If we check now, probably the first ones are appearing. There is a race now to begin trials of Ebola drugs and vaccines within this outbreak, and we hope for the best. If you want to summarize what clinicians need to know, well, we have in a rapid communication in clinical microbiology and infection, we summarize when to suspect the disease, what the clinical features are, how to diagnose it, and what to do with regard to treatment and supportive care. And the most important take-home points for those brave colleagues working in the area is that you have to think of it earlier. You need also to broaden your diagnostics right at the beginning to account for differential diagnosis, and early isolation and limiting of secondary cases is paramount. Now, we had a other webinar organized end of May. This was different in character, not one boring person talking from A to Z, but we had, like myself in this case here today, but we had brought 5 or 6 experts together, alluding to different aspects, and most importantly, we had colleagues from the field. This can be revisited and looked at. It's different from what I did this morning, or I'm doing this morning or this afternoon. If you visit the ESCMID webpage, you can find this webinar. End of last week, we published a podcast with CMI Communications, also freely available, where I had the pleasure to work together with Daniel Bausch, a very, very high-profile expert of filovirus disease, where we are discussing in a sort of sofa atmosphere all the aspects of which most I touched upon today, but much more into depth. And for those who are interested in what to do, if you are voluntarily or involuntarily finding yourself in an outbreak situation, this is a course we did 10 years, or we initiated 10 years ago, where we touch upon all the basics you need to know when getting embroiled in outbreak control. And it's still it's active. These are figures from yesterday. So although it is not covering the latest developments over the years, for clinical practice, this is still all you need to know. So if you are interested in doing parts of it, also you are very welcome. And with this, I'm coming to an end. I apologize for the technical glitch in between. I don't know how that happened, but I'm happy if you were able to listening and watching the rest. And with this, I'm returning the word to our chair. And thank you. And I'm very happy to answer questions.
Thank you, Prof. Martin, for the great presentation regarding Ebola, updates on Ebola, how to prevent, and how do we need to respond, and update regarding vaccine and treatment. Okay, so I think we already have several questions. For the chair. Okay, thank you. So we have several questions. Okay, so the first one is from Aisha from Saudi Arabia. She asked about what lessons from previous Ebola outbreak in Africa that do you think are most relevant for countries like Indonesia in preparing for future emerging infectious disease?
Right. Very easy and very, very difficult question at the same time. I think the question of what we can learn from previous outbreaks, if we extrapolate from Ebola, I think the whole world is thinking about what have we learned from COVID and how can we be better prepared for the next pandemic. So first of all, the filovirus infections will never grow out into a pandemic or so. So also in Europe, we are always asked or confronted with the question, if we now get secondary cases in Europe, will we have a problem? The answer is no. Even if we don't recognize single imported cases early, in the worst case, that's bad enough. If basic isolation rules also are violated, there might be the one or other nosocomial case, but due to the need that you do have very close contact with a ill person, these outbreaks, even if things go wrong in the beginning with violation of basic infection rules and a non-recognition of this rare disease, this is never going to develop into a big outbreak. The second thing to learn is, I think, implementing very simple infection control rules when encountering an infectious or a patient with a suspect infectious diseases, particularly when he or she comes from out of area like Africa or so, is paramount. Even without specialized suits, if we wear a mask, if we wear a long sleeves, if we wear gloves, we are already very well protected. Not 100%, but very well. And I think that should give us reassurance. The third thing is, what can we learn from this outbreak? It's general preparedness for being faced with the unusual. I would say if you saw a patient from your area with high fever and some bleeding signs, your differential diagnosis would not include the filoviruses. If somebody comes from another area of the world, in that case Africa, early awareness of the possibility would make all the difference, even if you don't have a diagnostic tool readily at hand. And I do believe the question which is very important is, can we get something like that as an autochthonous disease in Indonesia? Now, as far as we know, there are no hosting animals throughout Asia, as far as we know. And we also don't know about affected macaque populations other than in the Philippines. But who would be able to say that it's entirely impossible that somewhere in remote rainforest areas there are more viruses lurking, and that could well include Indonesia also. So I think awareness, One Health mechanisms to be prepared are very important. I'm saying by no means that I'm expecting anything like a filovirus disease spreading through Asia, but we should be aware. It might also be possible that over the years, the reston virus, the Philippine area, alters its virulence, and then in the far future, probably far beyond the end of our medical careers, including that of the younger ones amongst us, I wouldn't fear that, actually.
Okay, thank you, Prof. Martin. So it's quite clear that, yeah, regarding the Ebola, it's quite several things that we can learn for the future pandemic. And then maybe the next question. Steady. Okay, this one is from Mr. Nurfianto. Is there any weakness about the current antivirals and monoclonal antibodies to combat Ebola? And how about the current research progress about the new drug discovery and therapies?
Yeah, thank you. I think I addressed this question already to the end that we do have tools readily attend vaccines and monoclonals against Zaire Ebola virus. We don't have them for Budibugyo. They need to be developed for the reasons which I mentioned. All we have is the implementation of good clinical care. That will make all the difference whilst we are struggling and pushing on with developing specific tools. But it has to be assumed that the current tools work so weakly that WHO concluded it is not worth wasting the scarce resources of Zaire Ebola virus against a virus from which we know or believe from animal testing that it's not going to work. Yeah, so the race is on to develop these specific tools. We don't have them at hand. Improving clinical care in the way I laid out in some detail is the key.
Yes, agree with Prof. Martin. Okay, so hopefully, Mas Nurfianto, you get your answer. Okay, I think next one. Okay, this is from Olivier. Based on your research, is this virus mostly sexually transmitted? It spreads through body fluid. Also, given Indonesia climate, could Ebola actually spread there in Indonesia? And what should we watch out for at the borders?
Okay, thank you. 3 questions. Now, it would be tragic if I was misunderstood. In principle, Ebola is very poorly sexually transmissible. This is an exception, an absolute exception. First of all, we are probably differently from the viruses which we most efficiently transmit and bacteria sexually. We are only posing a risk to others if we are diseased. And if we are diseased, it's very unlikely that there is a lot of chance to transmit the disease sexually. All I'm saying is that we discovered that in healthy, recovered males, the virus might survive for years, and there have been cases documented where recovered male patients spread the disease without knowing they were still harboring the virus to their sexual partners. But that is an exception. Yeah, the usual way of transmission is through close physical contact with a diseased person or a deceased person. So it's the next of kin and hospital workers, healthcare workers who have the biggest risk. Now, with regard to climate, well, I would say climate itself plays a small role because this is not an environmental or a vector dependent agent which depends on the environmental temperature in a vector. I would say the risk for autochthonous disease, I tried to highlight it already. Nobody can really exclude that a filovirus disease is somewhere harbored by a suitable a host somewhere in the still vast rainforest areas of the Indonesian archipelago. Until now, we have no evidence at all for this. The one virus which is harbored or at home in Asia, in the Philippines, Reston virus, has been documented to spill into humans because we find seropositive individuals, but there is not a single case of disease which has ever been recognized. So for the time being, there is very little risk of autochthonous disease. What do you have to watch out for at borders? Well, basically, I wouldn't fear land borders that much, but if you do have travelers who are from, or who have been in Africa, sporting a fever whilst they are coming from an outbreak area, and whilst they have been in touch with patients, those patients should be handled as potentially being infected. But it doesn't make sense to put, let's say, febrile travelers from a whole continent under suspicion. So when you are confronted with a febrile traveler from Africa, think first of malaria, think of the usual things. See whether there is an outbreak going in that area and whether there are risk factors. If that's not the case, it's statistically almost impossible that you will be confronted with the first index case of a very rare disease coming from a different continent. That would be my answer to all three questions.
Okay, thank you, Prof. Martin. Yes, it's quite exceptional to transmit from sexually for the Ebola, and then I agree with Prof. Martin that we suspect, especially for people with fever and have a close contact with Ebola case. But if it is only a fever, then yeah, we can think of many other diseases that potentially have similar symptoms. Maybe next question, I think.
There are questions also in the chat, but I see there are more questions here. Should countries in preparedness even when there is? Yes, absolutely. And this is happening, actually. The problem with this specific outbreak, if we look at the outbreak history of the past 10 years, there are now a couple of outbreaks which have been very, very rapidly brought under control. There were small outbreaks in Uganda, in Rwanda. They were identified early, clamped down on immediately. The problem here is the combination of a vast remote area and disruption in terms of it being a war zone. And that makes it so difficult because health structures are imperfect. It's very difficult to even communicate between centers. There are many, many reasons why it's going not so well with this outbreak so far. And the reasons are all human. It has to do with the disruption in the area. It has to do with the fact that this is not a peaceful area where an outbreak can be recognized earlier and clamped down. But I would say there has been an enormous lot of investment into infectious diseases preparedness around the globe, not necessarily due to Ebola, but certainly due to COVID. And that also includes the African region. So matter of factly, African colleagues need to be commended for the capacity which they built over the past couple of years. But the problem is if outbreaks originate from highly complex areas like the one now, then all our infrastructure which we built up over the past years might be jeopardized and might not be enough.
Okay, thank you, Prof. Martin. Yes, and then I think so. We still have several questions. Next one is from Nur Farida.
Yeah,
I think it's similar with the previous one. What other
but maybe important. There is one important aspect, and that is, does WHO recommend travel restrictions? And there are good reasons why this is not done. So there are no travel restrictions at present, and that implies to foreign visitors, both as to people in the region. Now, let us start with foreign visitors. There is no tourism activity in these areas, and everybody who is considering going there now knows about the outbreak and will be a healthcare deliverer or somehow evolved in outbreak control. If we look at travel restrictions to the DRC, imagine this country is so vast and the capital cities of economic activity which are linked to other centers is thousands of kilometers away. So in European terms, it would be as if we are in southern Portugal and there is an outbreak in Moscow. We wouldn't worry in Portugal. And that's the same why there are no general travel restrictions through a DRC. If you overlay Congo on the Indonesian archipelago, I think probably it's 3,500 kilometers from the outbreak area to 2,000 at least to the capital city. It doesn't make sense. And the other reason why WHO doesn't recommend and the countries don't implement border restrictions, the point is the borders are porous anyway. And as long as people are still allowed to move between countries via the main roads, it's very easy to do temperature checks, to inquire about symptoms when people use the main roads. But if you prohibit use of this, people will pour and use the porous borders, and then you might achieve the precise opposite of what you would want to do by issuing travel restrictions. So at present, no travel restrictions.
Okay, thank you, Prof. For the answer. So there is no travel restriction yet for Nur Faride. And then I think we still have two more. Okay, this is I think from the same Aisha from the first question. Are there any reason on the why there is a development in intranasal vaccines? How do these intranasal differ from regular, and what is the benefit at present?
Well, first of all, it's only under development, so we don't have these nasal vaccines now. But what would be the advantage of a nasal vaccine? Now, the question is, in a way, very simple for a clinician. Actually, imagine what you would do is we are talking about an Ebola vaccine, and they will always be relatively scarce. So what we are doing in an outbreak is we are vaccinating contacts, people at risk. Now, a nasal vaccine would be ideal because you wouldn't have to, you could keep exposure of healthcare workers minimal. It's something entirely different whether you need to insert a needle into something or whether you could do something simple as administering a nasal spray. So as a delivery tool, I think a nasal spray would be ideal, but we are very, very far from the practical applications. But every clinician will probably agree, every public health specialist. Imagine you are tasked to vaccinate 200 people. Now I can tell you, if you have a well-working intranasal vaccine, you will be much, much more quicker with much less equipment than if you have to vaccinate 200 people intramuscularly. So I would say a nasal route could be, intranasal route could be of great, great benefit for vaccinology at the whole. But I think we are still very far from it. But apparently, depending on which vector you use and the nature of the vaccine, if that might be an option, I think it would be ideal.
Okay, thank you, Prof. Martin. So that's the answer, I say, because it's more helpful and minimize contact. That's also one of the advantages of intranasal. Okay, next, Mas Dedi. Okay, oh, this is from the chat. First one is from Tawaki. If another emerging pathogen appeared tomorrow, what do you think would matter more, the technical expertise or the ability to build trust with communities, and why? And then I think the second one is we have discussed many evidence-based intervention for Ebola, but implementation often remain the biggest challenge. In your experience, what separate countries that successfully translate evidence into action from those that struggle despite having access to the same knowledge?
Yeah, thank you. With regard to the first question, I think I would ask the question slightly different, because I do believe you need both the technical experience and the availability of tools. But for sure, and Ebola is a very, very good example for that, without without building trust with the communities and working with and through the communities, you are lost. Ebola care is very disruptive. People are forced to abandon the cultural practices which are very close to their hearts. Imagine, usually a whole community would bury somebody and everybody would touch the body of the deceased. This is how Ebola is transmitted. So there is no way in not disrupting these practices. And you can imagine how important it is to work through the communities to establish the trust and to allow for the insight to be developing, that certain things are simply needed, even if they are at total odds with practices. And so our technical knowledge is worth nothing if we don't work through the communities. That would be the answer to that question. And the other one, if you could put up the question again, please. It was about which countries are
successful in implementation, and what separate country that's successful in implementing.
Well, I think the main difference, so firstly, once again, we need to recap that if it was Zaire Ebola virus, we would have other techniques, we would have vaccines, we would have monoclonals, which could work. Here, we still need to develop them. So the response in this case is more difficult anyway than it would be if it was the virus which has been involved in most of the outbreaks against which we do have interventions. But the problem is always, it will depend on the level of investment and the availability of resources to a certain extent, how effective and early an answer can be. And the reason why it's difficult here is it's not the healthcare workers are of the same level of devotion and excellence than in other parts of the world. The problem is remoteness, difficulty in communication, limited access to resources needed to mount an early effective response against the disease. These are always the same reasons, actually. And there are others. There is still a human factor. So even a country which is maybe investing a lot into early recognition and preparedness might be caught offhand. It's thinkable. Infectious diseases are highly complex, and this is very, very, very easy to misread a developing outbreak in the beginning. If you are interested in that topic, with the EIS, we have recently published a paper last year where we try to analyze why early outbreak recognition and control can go wrong. And it's mainly the human factor. It's not necessarily resources. It's that we are misled. In an area where you have lots of febrile disease with watery diarrhea, Ebola is and remains the exception. So if it's emerging now in a particular setting at a particular time, then it can be easily mistaken, and that cannot be counterbalanced by at all times and in all settings. So it will be an eternal struggle against emerging infectious diseases, and we will lose some battles. We will lose some battles. And that's not necessarily country specific. We cannot say that poorer countries are in general less well prepared than richer countries, because what it all depends on is the ingenuity of the human brain, early recognition, etc. And there, the poorer countries are not necessarily at a disadvantage.
Okay, thank you, Prof. Martin. I hope that answers your question. And then, please, Mas Dedi, could you swap? Okay. So next one is from Cornelius. It's from the chat. So Cornelius asking about the feasibility of outbreak control without vaccine. Given that in Budibugyo Ebola virus there is no licensed vaccine, and considering the uncertainty around current reproduction number estimate, do you think non-pharmaceutical intervention alone are sufficient to control this, and how long the government could handle this outbreak properly without an accelerated vaccine?
Thank you. Yeah, I think I discussed some of these questions already, maybe from a slightly different angle of approach. So first of all, at present for this outbreak, all what we have is improvement of routine clinical care. This is important, and that makes all the difference. In the absence of working vaccines and monoclonals, and still even if we had them, the improvement of clinical services, the construction of treatment centers is in the end essential in turning the tide. Vaccine development takes time. At least a couple of months, if not a year. The question will be, will this outbreak be long enough? And we are here, we have contradicting interests. For the sake of vaccine and drug development, I don't want to be mistaken here. We are certainly not hoping for a long outbreak. The opposite is the case. But we would still need an outbreak which goes on for quite a while in order to push on with drug development. We still wish that the outbreak is brought quickly under control. At present, it is completely unpredictable how long it will take to bring it under control. Will there be more than 3,000 patients than in the second largest outbreak ever? Will it be less? If we look at the current figures of new suspect or confirmed cases and deaths per day, per week, then I'm not optimistic that we will be able to get that outbreak under control within weeks, maybe not even within months. So, but it's very, very unsafe, even for specialists, because our information is limited at that stage, to try a prediction when this outbreak will be ended. But I'm afraid it will go on at least for a couple of months. And that period will be used to push on with drug and vaccine development in any case. The question will be how far we will get.
Okay, thank you for the answer, Prof. Martin. Hopefully, Mas Cornelius, that's satisfy your question. Next, Mas Dedi, is there still any question? Okay, we still have 3 more. So, from Marx, are there potential solutions to the ethical dilemma involving trial of vaccine that have already shown promising result in animal study? So I think it's...
Thank you. Now, what constitutes the ethical dilemma in Ebola vaccine trials? So firstly, it's the fact that even if a vaccine works well in animals, we still need to push it through clinical trials. Yes? So maybe to a certain extent, phase 1 trials, which do not require patients, could be done quicker and should be done quicker. But with phase 2 and phase 3, we need these outbreaks. Now, an outbreak, per definition, is a chaotic and scary situation. And whereas we take our vaccine and drug development usually to well-developed centers in a structure, in a setting with good infrastructure, where there are cases in abundance, this is what we do normally. But the Ebola situation is entirely different. We want to develop vaccines or drugs which are needed by those who are contributing as probants to the trial. So the key ethical issue is we need to do this double blind and we need to do this randomized, which means inevitably 50% of the study participants will receive the intervention, which we think will work, and the other 50% will not receive it, but with a delay which is big enough to, on the one hand, allow for us seeing differences between vaccine administration and non-administration, and on the other side, being designed in a way that it doesn't disadvantage the control group overtly over the intervention group, because that would mean if your life would depend in a clinical trial from chance being randomized to the one or the other group, that is our basic ethical dilemma, which is difficult to overcome, but which we are addressing in modern study designs. Does that answer your question, Mark?
Okay, I think hopefully it will answer this question. Thank you, Prof. Martin. Then the next one is from Meristica. Ebola symptoms are non-specific. Testing is time-consuming and transmission ongoing. What is your advice for management at point of entry? I think it's quite similar with the previous one. And how to strengthen health resilience at points of entry?
Yeah, very, very good question. I think in part already addressed during my talk. It is true the symptoms are unspecific. It's also true in most cases. It's also true that there is a risk for healthcare workers dealing with patients and with regard to carrying out tests. So usually we do something in an Ebola outbreak situation which is completely at odds with our usual practice. We will only take one blood sample and confine that to the diagnosis of Ebola. But for bacterial infections, for malaria, which account for maybe in the end 60 or 70% even of the suspect cases, we will simply administer those drugs right on first contact. And maybe an hour later or 2 hours later, the malaria patient who is not an Ebola patient will start to recover. The same might apply to the patient with a bacterial infection but no Ebola. So symptomatic treatment is really absolute key, and that is what makes a difference during an outbreak.
Okay, thank you, Prof. Martins. I think this is the last question from someone that didn't want to know anonymous. Vaccine are difficult to find due to the diversity of strain. But if a future Ebola vaccine is successfully developed, which age group or population will be most appropriate?
Yeah, very good. So for vaccine, there exist different concepts which we have to apply to different situations. So first of all, many vaccines, and that includes Ebola vaccines, are of limited protection duration. Yeah. The other thing is Ebola is a is and remains a rarity, even in an outbreak situation. So from a public health point of view, for 2 or 3 reasons, it would probably make very little sense to mass vaccinate populations. Because even if you look at an outbreak, it's an extremely small number of individuals which will ever develop the disease. And they might develop it many years after vaccination campaigns. And hence thus the effectivity will be limited. The point I'm trying to make is that at present, it doesn't look like as if it was feasible nor wise to mass vaccinate populations. We will probably be confined, for all the reasons mentioned, to vaccinate contacts during an outbreak. And this is already common practice in West Africa. In the area where I was working, where I am working in Sierra Leone, a couple of years ago, there was an outbreak beginning to start, and health officials immediately moved in and offered the vaccination to healthcare workers. Very, very wise move. The best working vaccine has a very short life, very short-lived immunogenicity. So it protects you if you are in the incubation period, because you are building up antibodies very quickly. But this will be gone, the effect will be gone after 3, 4, 5 months. The ideal vaccination for outbreak situations, but not a good vaccine for all the reasons mentioned, including cost and efficacy, to give as a childhood vaccination. At least we are at present far from that. So the answer would be, you would vaccinate 2 groups of people. You would vaccinate only during an outbreak, and you would vaccinate healthcare workers and contacts. That's the answer to your question.
Okay, thank you, Prof. Smart. Is there still any question, Mas Dedi? So I think there is still 2 in the chat. The first one is from Dr. Rustam Siregar. Is there any difference about clinical sign and symptom of Ebola in adults and children? And then the second one is there any protocol from Dr. Tri? Is there any protocol being prepared to take care of mental health issue among healthcare workers?
Yeah, the answer to question 1 is no. Yeah, that's easy, as far as we know. And the second one is that for sure there are protocols for those institutions which deploy people into an outbreak situation. So that's for acute healthcare workers. And then it depends on countries whether they do have protocols in place for post-trauma, post-infectious diseases situations. What we know is that many countries, an Ebola infection comes with great stigma. And to that end, in any case, with many problems, they can be economic to societal, to psychological, or even psychiatric. And I do believe that in outbreak countries, many countries do have at least basic possibilities to assist survivors. But whether this is everywhere the case and up to a level which would be needed might be doubtful. Yeah. So mental health is certainly something. There was a paper published a couple of weeks ago, accidentally coinciding with the Budibugyo outbreak, where a group of Congolese researchers looked exactly in the mental status and the mental health of survivors from the outbreak from 16 years ago. And it really shows, and I know that also from interviews with survivors, mental health is a enormous problem in the aftermath. And surviving is not enough. Huh? You want to have a decent life. You don't want to be stigmatized, and you might need help with many aspects. Very important point.
Okay. Thank you for the answer, Professor Martin. I think that's all from all of the question from the chat and the Q&A rooms. Okay, maybe is there any more questions? Okay, I don't think so. So that's the last question from our side from the participants. Maybe before we close this session, Prof. Martins, do you have any one or two key takeaway points to give to the participants?
Thank you. Yeah, I think most points were already made. I do believe the most important thing is that whatever we do as healthcare or laboratory workers, exert preventive measures, basic measures. Don't violate the basic rules of hand hygiene, of wearing gloves, wearing a mask if you think of an infectious diseases. And that way you would probably be already, maybe not optimally, but very well protected against bad surprises like highly contagious diseases. Secondly, at present, the risk for a autochthonous disease in your area of the world is very, very, very low. And the risk of imported disease is also very low, but that doesn't mean we are living in a world where we have witnessed over the past couple of years that novel pathogens may spread rapidly. The filoviruses are not amongst them. What we need to be aware of is all sorts of respiratory transmitted pathogens. There is little to learn from Ebola, particularly for outbreaks of pandemic potential for the future. I think that's how I would wrap up.
Okay, thank you very much for today's session, Prof. Martins. Hopefully, it will give us a more detailed and clear explanation regarding Ebola and what do we need to know, whether it can be a next pandemic, and that's already answered by Prof. Martins. That is quite low, the likeliness of becoming the next pandemic, and what is the things that we need to prepare, and what do we know to prevent the transmission of Ebola. I think that's all from me. And thank you again. Please, from the participant, if you can give like round of applause for Prof. Martins. Okay, thank you very much, Prof. Martin.
Thank you very much for joining, and thank you for facilitating this meeting. Many thanks. Have a good day.
Have a good day, Prof. Martin, and see you again.
Bye for now.
Bye, Prof. Martin. Ya, untuk peserta jangan lupa ini ya, attendance list-nya monggo silahkan diisi. Sambil mengisi, saya izin untuk menutup sesi hari ini. Terima kasih semuanya. Selamat sore. Semoga ilmunya bermanfaat bagi kita semua. Selamat sore. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.